Well, thank you for inviting me to come. I've never been here before. It's lovely here, isn't it? I wonder what other meetings I can do here. And I chair the Kenton Medway Rheumatology Group, and we've just been kicked out of Kim, so I'm eyeing up this place and maybe able to use it. Now, I've been asked to talk to you for a long period of time. It is late in the evening, and a lot of you are tired, you've had busy days, and some of you would have told me you're going to fall asleep within 5 minutes. So I'm going to try to keep this interactive. If you've got questions, hands in the air, I'll bellow them out. Because I've done a doc talk here, but talks can be a bit boring, and it's often more fun to actually go where your thoughts go. Okay? So feel free just to shout out. So that's me. I've been asked to talk today about rheumatoid arthritis, which I could talk forever on that, but I would bore you stupid. Hypermobility syndrome, which you all see, and actually data is a little bit scarce, but I will go through that. But more importantly, anything else you want to go through, anything else that I do you may want to be interested in, or questions, and I have my own pet theories about certain things which I'm quite happy to go over during this time. And any questions either at the end or I prefer actually going through when they're there in your mind. And please don't be shy and shout out. So, what is a rheumatologist? None of you know, do you? Well, they're my parents. They don't know what I do for a living. It's something to do with blood. That's my daughter. She hasn't Scooby-Doo what I do, but I just buy it for the computer games that she wants. That's my other daughter, Evie, and that's who we're collecting for this evening, who just had a cochlear implant done at Great Ormond Street and doing very well. That's my other half, who sort of knows what I do. They don't care, they just have to be fed every day, but they give us lots of eggs. Unfortunately, the day after I took this, the fox had all three of them. So my poor chickens are all penned away now. I think this was 2 years ago, so they're all penned away, they're desperate to get up. Do any of you have chickens? Yeah. You feed them in the morning, they kamikaze you to try and escape. And then when they do, it's fun and games to try and catch them, particularly when you're running late for work. So, what is a rheumatologist? A physician who treats arthritis, rheumatic and musculoskeletal conditions. Some people none the wiser. And there's lots of definitions out there. We see all sorts of things. We see inflammatory disease, medical orthopaedics, both complex and simple, metabolic brain problems, and there's a whole panoply of things that sort of landed on our doorstep purely because nobody else wanted them. And actually about 40 years ago, rheumatologists especially were starting to die a little bit, and they sort of took lupus and took osteoporosis and took a bit of this and a bit of that, and so we've got a bit of a ragtag about things. But how do you become a rheumatologist? By the way, if you all know this stuff, tell me to shut up. You have to be a doctor, so you have to go to medical school. I went to Guy's, and then halfway through I was at Guy's, it turned into Guy's and St Thomas's, which was annoying, because they were the enemy. You spend a year as a junior, well this is what you do now, a year as a junior house officer, or an FY1, all buggies, then an FY2, foundation year 2, and then you have a couple of years as an SHO, or core medical trainee, 5 years as a registrar, a bit of research sandwiched in there, and at the end of that, if you manage to get to the end, then you become a consultant in whatever field you want to do. I have to do rheumatology. Because I like my patients enormously well, and I thought the people who did it were very pleasant as well. But I wanted a specialty which wasn't smelly. I can spot Pseudomonas from 50 yards. And many years ago, I had to put a chest drain in somebody who had an anaerobic impairment. They had pus around their lungs. You've all smelled gangrene? Yeah. Imagine that over an entire A&E department. It was in Eastbourne. I was in lots of trouble because they had to close it. You couldn't have people in there, it was hideous. So I didn't want to do that specialty either. So I've got a relatively non-smelly specialty, and I've got lovely patients. So we look after all sorts of different conditions, over 100 types of different arthritic conditions. Some are very serious, some are very mild, but of course the severity of disease has nothing to do with symptoms that people get. But often people tend to complain more who have what we would call the milder disease. And we've got something they call cognitive specialists. We have to think a bit. Perhaps I would delude myself slightly. I think I'm a bit like Sherlock Holmes. I have patients coming in, they don't have a diagnosis stamped on their forehead. So you have to sort of formulate a hypothesis, try and work out what's going on with them, and see if they fit that hypothesis or not. Sometimes it's easy, sometimes it is not. Sometimes I'm right, sometimes I am wrong. And I think the hallmark of being a good clinician is to know when you've made a mistake and actually you've got the diagnosis wrong and actually have to revisit that. So that's what we do. We're actually relatively cost effective because if you have a rheumatologist who's relatively good at what they're doing, they don't need to do x-rays. Like you guys, imaging is not that necessary, but if people don't know what they're doing, they tend to x-ray, MR, stuff, and you end up by over-investigating people. And that's expensive. And particularly with our healthcare environment we have at the moment, a lot of things, the NHS is in complete meltdown, as you know. So rheumatologists are great, but we don't have many of them. I go to our national conference, the British Society of Rheumatology, and okay, it's actually bigger than it used to be, but there's about 1,500 people there. And they come from all around the world. The European conference, last one, was 18,000. The American one is over 20,000. In the UK, the government say we should have one rheumatologist for 85,000 population. We are probably getting close to about one per 110,000 at the moment. In France, they have 4.2 rheumatologists per 100,000 people. In fact, I like using the stat of saying there are more rheumatologists in Paris than the entire United Kingdom. But they tend to do, in the continent, they tend to do a lot more musculoskeletal work. And they have a different way of training in continental Europe. We have a system with the training pathway that you see there. A lot of the specialists in Europe tend to be in that middle grade, the registrar level. And so much of musculoskeletal medicine is done by GPs. And what do GPs know about musculoskeletal medicine? Some a lot, some not very much. So often, with 8 minutes to see a patient is have some pills, which is why you've all got jobs, which is great, isn't it? Because it is hard for these guys to try and deal with this, and actually a lot of them don't have any formal training in musculoskeletal medicine, which is bizarre, because the commonest reason that people don't work in this country is, the second commonest is, and then it's psychiatric conditions. So they do a lot of psychiatry training, but they don't do any of the other stuff. And the use of, in my own opinion, this is not from the naturalists, I think the treatments for these conditions are suboptimal. I think we use a lot of medicines which don't really work very well, but it's we're poisoning people. So that's what a rheumatologist is, in a nutshell. And if anybody wants to fire up questions, please feel free to do so. You've all gone to sleep already. Fantastic. Come on. This is trying to die on me from the beginning. So, I was asked to talk about rheumatoid disease, rheumatoid arthritis. Now, I use the term rheumatoid disease very accurately here. This is not a joint disease. This is a multi-system autoimmune disease. This is where the body's defence mechanisms are targeting you. The bits they target the patients complain about in this condition are the joints. Classically, the peripheral joints. But I use the term rheumatoid disease, and that's what I say to the patients as well. Now, all the literature is all about rheumatoid arthritis, but we had a health secretary at one of our national meetings a couple of years ago, and we had a whole session on rheumatoid arthritis, and this health secretary said, yes, I know it's about arthritis, this disease, my grand's got it in her knee. I think it was Labour at the time, actually. It was a while ago. And to use the term arthritis, people think that's all this problem is, but it's not, and I'll come round to that in a second. So what is the definition? Well, these are the definitions I pulled off various governmental and international websites. It's a chronic, systemic, autoimmune disease, autoinflammatory disease. Chronic, it's there all the time. I'd say I get beer in my body and people say, oh, my pain, doctor, it's chronic. So it's not. We use the terms incorrectly. But anyway, that's me, it's a bit sad. It's systemic, it's the whole body is affected. And the body's defence mechanisms are fighting itself. The symptoms of rheumatoid arthritis, predominantly in the joints, is inflammation of the joints and the structures around the joints. With the things you can see here, with pain, stiffness and swelling, deformity, and the joints actually being damaged and fusing, and the other things. You've all seen these patients, yeah? Yeah?
Yes.
Oh, I can see the Z's over some of your heads already. So these are what does this actually project-ish? Okay. You can see on some of these pictures, if they don't show well, I'm very sorry. Inflammation in the joints. Who has it? It's actually very common. As an autoimmune disease, it's one of the commonest ones we have. Probably apart from thyroid disease, which is common, which is the one that affects most population. About 1% of the population will get it. Now this is for people in the UK. Different populations have different numbers. It's more common in women. Women's immune systems are strange things. Unfortunately. The blokes here, yeah? Okay, the blokes. You get a cold. Your wife's had a cold and she goes, I've gone to work and I'll be fine. You get a cold, it wipes you out. You got man flu, yeah? 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 Women's immune systems are better than men's. Oh! They fight bugs better. That's because you guys have something called estrogen. Lucky you, sort of. So when you get the bug, you fight the bug better. There's a other side of this though. When your immune system is being overactive, it tends to hit you more. So women are hit by autoimmune diseases much more commonly than men. Rheumatoid disease, 3 to 1. Sjogren's syndrome, 9 to 1. Lupus, about 6 to 1. When men get it, if it breaks through the fact you don't have estrogen, they tend to do worse, but men tend to do worse at lots of things anyway. Because we're a bit rubbish at that. So this hits women more than men. There's various different studies which show the time that it hits most. It's often women of childbearing age for the estrogen effects. There was a second spike which you see later on after menopause, and it's a slightly different condition in that time. And then the other time it is after women have babies. You know, but those of you who've had babies, afterwards your hormones are all over the place. And loads are as well. That hormonal shift can be a real trigger towards all sorts of autoimmune diseases. And that's probably an estrogen effect, and maybe some of the other hormones are in this effect as well. And it has a significant morbidity and mortality, so it damages you and it kills people. In the old books it said it took 9 years off your life. I published a study many years ago on this, which is looking at a national cohort of patients, and the risk of dying of rheumatoid disease is an increased risk of symptoms of diabetes. So this cohort was the historical cohort, however, before decent therapies were available. The other thing which I'll come to second, it's possibly a condition from the New World. There were no archaeological remains in Europe prior to the 16th century of rheumatoid arthritis. There is gout, there is ankylosing spondylitis, it's wear and tear arthritis. In fact, ankylosing spondylitis, Ramesses II had ankylosing spondylitis. If you look at his CT of his skeleton, which is the University of Manchester. In fact, they had to break his neck to put him in the sarcophagus. But he lived to 87 and he had 300 children. And so if people got Antoine, maybe related to him. However, in the New World, 13th century excavation from a 12-year-old in the 13th century had damage which looked like rheumatoid disease. Apparently that is a Pima Indian. Native American, sorry, I'm being a bit politically incorrect. These people have a very high risk of rheumatoid disease. Up to 10% may get it. There's a hypothesis, and this is only a hypothesis, not everybody believes in this. When Christopher Columbus sailed across the Atlantic to the New World, what he took with him was chickenpox and smallpox, which eradicated 95% of the population. He brought back potatoes, tomatoes, syphilis. Actually, do you know the story about syphilis? Sorry, I don't mind I digress a bit because it's a bit boring just doing this otherwise. You know pirates, yeah? You know why pirates stop? Why? Because they've got syphilis. They can't feel the deck rolling underneath their under their feet, so they have to stop. So they actually feel the deck, otherwise they fall over. Why they got parrots, I haven't a clue, but there we go. Anyway, so where was I? Yes, we brought back potatoes, tomatoes, and tomatoes may be relevant to some forms of inflammatory disease. Tobacco, which we'll come to. Syphilis, possibly brought back something that could cause rheumatoid disease, because when we started to see it spread around Europe. We didn't get into Africa into Gambia until the first case in Gambia was in the 1950s. Now there may be genetic factors behind this, but it sort of suggests there may be other factors apart from genetics here which can drive this condition.
Sorry, could that not be the amount of vitamin D they'd be having in Gambia compared to Northern Europe?
Well, you could be right, but most people who live in Gambia don't go out during the midday.
But they're still out at some point, so they're still going to get more sunshine than you are in Northern Europe.
Yeah, you may be right, but I have to say, the vitamin D story, I'll come to that later. Vitamin D, if you've got dark skin, you get less vitamin D from the sunlight. But I mean, there's a woman who comes to visit me every couple of months from Nigeria, and she doesn't go out in the midday. She goes out in the morning and in the evening. In the midday, she doesn't go out, it's too hot.
Yeah.
And they wear big hats. So actually, you may find that these people are vitamin D deficient anyway. And a study from Hawaii about 20 years ago showed that 70% of people are vitamin D deficient in Hawaii.
Right.
That's clothes, sunblock, I don't know. Could it be vitamin D being the story? We may possibly, and we'll come to that later. This was Rubens, who's an artist. This is the only self-portrait he did. He's got swollen fingers. Who's that? Renoir. Look at the way he's holding his paintbrush. He was a father of Impressionism. When Renoir started, he used to paint like everybody else. That's how he held his paintbrush. He could only dab. It is my contention, no, we're not debating this today, so it's a good point to say that. My contention, actually, rheumatoid arthritis is what caused Impressionism. You may not believe it, but you'll remember that, if nothing else. So which joints get affected? It's the small joints, the peripheral joints. Exactly why certain joints get affected and other ones don't, we don't know. We really don't know. The wrists, very commonly affected. The MCP joints. Yeah? You okay with that? Yeah, MCP. PIP joints. Yeah. The ones at the end, the GIPs, never get affected by rheumatoid disease. Never, ever seen it. You can get osteoarthritis in it, but they don't get rheumatoid. And we don't know why. We don't know why. Elbows, shoulders, yes. The spine's not affected by rheumatoid disease, except for one bit. Right at the top. So if you see somebody who's got rheumatoid disease and they've got neck pain, be very careful, because the adductor axial joint Yeah? It's like that. Sorry, being rude here. It's like this, yeah? This is a big synovial joint that erodes. What happens is the odontoid bed disappears, and this is unstable. So if you're manipulating somebody's head who's got rheumatoid disease, be very, very, very careful. In fact, I probably wouldn't do it unless you had imaging to support that. But the contention is, if you've got a painful neck bone, it is protective. If you've got bad hands, you think about bad necks. Fortunately, because of treatments, most of our patients don't get into that sort of stage now. Knees get affected, hips get affected, probably in the older patients, and of course in feet. So it's a small joint, it's asymmetrical, in fact both sides, probably because so many joints are affected. Again, knees, this used to be 20 years ago, orthopaedic surgeons, 90% of their knee surgeries were rheumatoid patients. Now it's less than 5%. It's been a huge success. It can affect other parts of the body as well. Skin, heart, lungs, eyes. Any part where the immune system goes basically can be affected. And the patients feel lousy. This isn't a joint problem. Who's had flu? How did you feel after the temperature had gone? Wiped out. There are chemicals, you would do a blood test then, they would be normal. So there are chemicals supposed to interferon, makes you feel rubbish. Achy, you lose weight, you just feel absolutely terrible. These people have this day in, day out, week in, week out. And actually what patients tell me with rheumatoid disease is, I don't like the pain, I can live with it. It's the tiredness that gets in, and that's what these patients really struggle with. So, first and foremost, it's an inflammatory, symmetrical, deforming arthritis. Which joints does it affect? These ones. The ligaments start to slip. Do you know the deformities you see of rheumatoid disease? Yeah. Why do you get a swan neck deformity? Okay. There's always who here is hypermobile? There's always one person. Thank you. Can I borrow you, please? You got hypermobile fingers? Yeah. Wonderful. Okay. So you're going to play with me here. Can you make your fingers do your hypermobile bit? Do your weird things where they bend back on themselves? Okay. Okay. Can you do the fingers where they?
Which way do you want to do this with my other hand?
No, not quite. Oh, there we go. So that's a swan neck deformity. Okay. The ligaments slip, and then what happens is the finger concertinas in because tendons want to shorten, so it does that. The other way, the Butonian deformity, is the button holder. So you hold a button, squeeze the button, and it does that. Okay? The ligaments are short. Coming off the production line. We're all different, and there are a subgroup of people who actually are stiff towards the end of the day. Yeah. Some patients with actually they don't have the stiffness. I've got patients who don't have pain, who've got erosive disease. I don't know why, but they don't. So always if somebody's looks like they've got classical inflammatory arthritis, but they don't have the stiffness, you think, well, it can still be that, but you've got to look for other things as well. As I said, there's over 100 different conditions we would have to consider in that situation. So you get it in your feet as well, so you get these toes pull up. And this is a particular problem because of footwear. If your hand is painful, you can't leave your foot alone because you've got to walk on it. And your shoes will press down, and these people often get pressure points. And the shoes have to get wider and wider. And actually here, the most important thing is getting a good podiatrist assessment. Because the whole anatomy of the foot will change. The ligaments slip, the foot collapses, and the bar mechanics change on. The foot is a wonderful piece of engineering. It's like a keystone bridge. All the bones are fit together perfectly. But when they slip, they start to rub. And these patients really try to solve it. What they say is when they start to slip here, is it feels like they're walking on pebbles. And the reason for that is if you look at your hand, if you look at your palm of your hand, there's a pad here under your MCP joints. Same as on your foot. What happens, that slips up, and the weight, rather than being on the padded bit, so it's floor, shoe, skin, padded bit, bone, that padded bit goes, it's floor, shoe, skin, bone. It feels like you're just walking on a hard surface at the time, which is just pushing it. And these patients get a lot of pressure points. And that can be very uncomfortable. So orthotics, very, very important.
So just a quick one with that.
Yep.
I've got psoriatic arthritis.
Yes.
Just in May, had a hammer toe pinned. And the way I actually got the surgeon to do it was I threatened to go in the car park and take my toe off with a hammer and a chisel. Because that's how much pain I was in from it.
That's slightly extreme. I'm going to go to patients because you'll probably get sued.
That's where I was with it.
Okay, well that's actually a patient with psoriasis rather than rheumatoid disease because you can tell by the toenails. So I cheated slightly there. I mean psoriasis, psoriatic arthritis, you know about psoriasis, people who have skin disease, it is another multi-system autoimmune disease. Personally, I think psoriasis is actually, do you mind if I go off a little one? Because if you want me to stop, just tell me. I think psoriasis is actually a bowel disorder.
Yeah.
Right.
I think it's a problem with your genetics interacting with the bugs in your bowel, interacting with the food that you eat. And we have most people, not all, but most people with psoriatic arthritis have what was called irritable bowel syndrome. I don't think it is. I think it's a microbiome problem. And I've had patient after patient after patient who've changed their diet, who have found the trigger, and what the triggers for psoriasis and the seronegative conditions are things like tomatoes, wheat, lactose, what I call sugar bombs, alcohol, red meat. They've found the trigger and they've avoided it. And I had one chap came to see me a couple of months ago, and I asked him to do a food diet, which I do for these patients, and he just sat at the desk and he went, Chinese takeaways. It's not normal, it says something when you first see it. He went, Chinese takeaways. And what he found is every time he had a Chinese takeaway, he was in pain for a week afterwards. So I did the Tommy Cooper line. Well, don't do it then. And he cured his condition by avoiding something which was a trigger. Now, it doesn't work for everybody, but for a lot of people it does. Psoriasis can afflict you just like rheumatoid disease does. In fact, there's a huge crossover between all these groups, and the nomenclature you use here is probably slightly artificial, because there's a lot of overlap between these different groups. And some of my patients get a bit annoyed because we start with one disease and move to another, but that's just what their condition is doing. And if you want me to go through, sorry, yes?
With the food stuff, mine pretty much, except chicken, I'm pretty much vegan now.
Yep.
I've cut out everything you've said,
yep.
But every rheumatologist I ever spoke to, where no, there's no link with food. I started, there's a guy called Pagano who's a chiropractor, started seeing what he suggested. Yep. Spent a lot of time on the internet, cut out red meat, alcohol, sugar, caffeine, dairy, gluten, potatoes, tomatoes, bell peppers, chilies, anything out of America. Okay, I'm on the biologics as well now, but before I started on those, I went from crippled to actually starting to be able to do things again.
Well,
but no rheumatologists that I've spoken to seem to get the food aspect of it.
Well, that's because the evidence base behind it is spartan.
Right.
And you have to. I'm a doctor. I spent all that time at medical school. I spent all that time studying. And what we're told is you've got to see the data. You're a scientist. You've got to have data. But we don't have all the answers. And I've given up many years ago thinking I had all the answers. I don't. And what those things I've told you is what my patients have told me has worked for them.
Yeah.
And now I'm getting patients to see nutritionalists. Now the NHS dietitians are not interested in this. But there are some nutritionalists who are, and they use probiotics and they use dietary manipulation. And I have lost count of the number of patients who that's worked with. I had one chap with psoriatic disease. I'm sorry, do you mind if I just go on my little meander? If I'm going too far, just call me. And he had failed all the drugs I used, including the drugs that cost £10,000 a year.
Are you talking about Humira or?
Yeah, all that sort of stuff. Humira, he'd failed Humira, Enbrel, infliximab, ustekinumab, cyclosporin, methotrexate, meflutamide, azathioprine, failed the works. So I had this talk with him because he thought I was getting nuts talking about food. And I said, look, cut out all these things from your diet. stop smoking, stop drinking, take vitamin D, take fish oils, get yourself healthy, get yourself fit. And he came back 4 months later with a bag, plastic bag, and says, you can have your pills back. He'd become a vegetarian. He had stopped smoking, stopped drinking. He had done this himself. Now, I mean, I could do a whole talk on that sort of advice if you wish. But, you know, these things do work for some people.
I was just going to say, don't you think that's because a lot of that takes time? And particularly hasn't got time in their 10-minute slot to go through all the things you can and can't do. It's far easier to say, here, take these pills.
I have 15 minutes, yes. I have a 15 minutes slot, so I have 5 minutes.
No, I'm not saying you, because you are more detailed than the GP, but I think...
But that's because I'm a specialist.
Yeah.
You ask me about child health or pregnancy, I wouldn't have a Scooby-Doo. Because general practitioners are general practitioners, and we expect them to be specialists in every field. And they can't be. It's impossible. I couldn't be a general practitioner. Their job is impossible.
Going on to the psoriatic arthritis with the coexisting indigestion. My father-in-law's got psoriasis, has had it for 50 years. He, first sign of it was diarrhoea and was diagnosed as ulcerative colitis by scan. Now, he has bouts of horrendous diarrhoea, still horrendous. He's on all sorts of medication. He's had his wrist joint every fused. Well, is that a different identity gut-wise because he's got another coexisting inflammatory condition in the gut, or would you still say maybe it's gone down the line of the gut more, like you said about IBS, which isn't really IBS? Would that generate?
Ulcerative colitis is inflammatory bowel disease.
Yeah.
It is part of the spectrum of conditions called spondyloarthritis.
Yeah.
Which includes psoriasis, ankylosing spondylitis,
Yeah.
eye inflammation down below.
Yeah.
My hypothesis behind this is this is a mucosal membrane injury which is leading to this problem.
Right.
And so inflammatory bowel disease, it is the microbiome in the gut which goes back and attacks the gut.
Yeah.
Actually, you can treat inflammatory bowel disease with poo transplants.
Oh, wow.
People go, which is why it doesn't happen. But it does work. There was when there was C. diff outbreaks 10 years ago, 12 years ago. Everybody tries to talk about how bad medicine hospital in terms of hospital hit. Actually, this country was not hit as badly as some other parts of the world. North America were very badly hit. In fact, a lot of healthcare professionals were dying of C. diff. There was one patient who was in an intensive care unit dying of C. diff, and they had a poo transplant from their best friend. And they cured the C. diff.
What's the poo transplant? Just take it out of one person?
Take poo out of one person, stick it up somebody else's backside.
Doesn't go through from the mouth?
You can take capsules of these things in.
Right.
And what happened there was the C. diff got better. But their friend had psoriasis. This person never had psoriasis before, developed psoriasis.
So the autoimmune.
Oh, well, they had genetics for it, but they developed this microbiome dysfunction. You want to talk about microbiome, I'm quite happy to do so, but there's a lot
I
of...
just wondered whether or not if he has an inflammatory bowel disease, would he still have the same beneficial effect like you had of doing these things to his diet? Would it have the positive effect, in your opinion? I know it's only opinion, but that's great.
Difficult to know.
His joints, so his joint pain and things.
But it's not a joint disease.
Sorry.
It's a multi-system immune disease, which is affecting the bowel, causing colitis, which is going to affect the skin, the joints, the tendons, the eyes, the liver, and other parts of the body. And he's going to, can I use medical language?
Yeah.
He's going to feel really crap.
Doesn't stop him eating the way he does, but maybe if I had some inflation to sort of say that maybe what you eat,
Well, we actually do treat Crohn's disease. There was a study using lactobacillus acidophilus, which actually helped treat Crohn's disease.
Oh, interesting.
If you look at the microbiome in Crohn's, the lactobacillus levels are low. And if you replace those, do you actually treat it? There's a few small studies on this, but these are small studies and very, very hard to do, and there's no money in it. So nobody's going to do the big studies. So there's small PhD studies, 30 people here, 20 people there, not big enough. It's hard to know, and it's very, very difficult to control people's diets.
Interesting.
So do you feel the same about RA with regards to the gut? Because I've read a couple of articles that have linked the gut to RA as well?
I'll come to that. Not quite actually. I'll come to that. But moving off track a bit. So, Charles, you know all this stuff, don't you? Yes, you know that. So this is what rheumatoid disease does. It damages people. Can we come back to your question later? And actually kills people, causes disability. If you, what's the chance of you becoming disabled? Increasingly time. Do you know about PAC scores? Have you heard of these? Health assessment questionnaires. This is a questionnaire that patients give. There's 8 domains, 4 upper limb, 4 lower limb, and they just fill it out. What can you do at home? And it is used for health economical modelling. A HAC score 3 is basically somebody's severely disabled, completely disabled, very severe, moderate disability. And as time goes on, you get more and more disabled. It means you can't work. These historical data, by the way. This is not what people with rheumatoid disease go through now. This historical data. So, you know, we're looking at people 20 years after developing this condition, and this is somebody who's in their 20s maybe, they're not able to work. And the thing about work is it's not just a person with a disease. Alison Carr did a study on this which showed that actually household incomes, if somebody has rheumatoid disease, household income dropped by 75% because the partner had to give up a lot of work to become a carer. It's a financially crippling disease. So what's the pathology? I'm not going to bore you with all this. Basically, there's lots of things that it does. These are a couple of cartoons. This is, you know what joints look like. It starts to damage. You have this thing called pannus forming, which is inflammatory tissue. It eats into the joints. It causes damage. That's the normal synovium. So these never project very well. It's normal synovium. Not synovium is the skin within the joint. Yeah. This is what it should look like. There's not a lot of things floating around there. Thin bit of skin. This is all these little dots are inflammation cells. So there's a lot of inflammation in there. This all gets thickened. These produce various chemicals. The important chemical here is one called a matrix metalloproteinases. And these are things that cause a lot of damage very quickly. Have you all heard of the gecko lizard? Mm-hmm. Yeah. The gecko lizard, when it gets attacked by a predator, what does it do? It sheds its tail. It does that because it releases these things called elastases and matrix metalloproteinases, and auto-amputates its tail very rapidly. The tail falls off, it's denervated, it wiggles around like that, so the predator goes, I'll eat the tail, and the gecko gets away. That's what these chemicals do. They are very, very, very destructive. And there's lots of brakes against this, but these become active and they damage joints, and they can damage them very rapidly. In fact, the condition that can damage them most rapidly is there's a variant of psoriasis which can cause the joints just to completely dissolve. Back to our old mate Renoir. This is his rheumatoid hand. And what we do, traditionally we did x-rays. 19th century technology, I don't know, these aren't his hands, but this is an example. So that's your patient, you do that, and you see the x-ray. The joints have slipped, these aren't smooth, there's holes in the bone. This is where these inflammation chemicals have literally drilled holes in the bone and dissolved it. You get closer, there's a hole there, that's what we call an erosion. You get closer again, this is a hole in the bone, inflammation chemicals. Again, this shouldn't be here. These are things called, these are T cells, these are immune cells. And these are, there are various different parts of the immune system. These ones cause local damage. B cells produce some of the antibodies that are part of this. And all these cells interact. Now, I'm not going to show you the up-to-date slide of interactions of T cells, B cells, natural killer cells, antigen-presenting cells, and all the cytokines, because to be honest, the tool's not big enough. And it looks like hieroglyphics, and it is a very, very complex diagram. And it's so complex, so complex we don't really understand it properly. This is a simplified these are things from antigen-presenting cells. These are, I use the analogy, these are sergeants at the desk in the police station. T cell comes along and says, look guys, I found something. Shows it to the sergeant and says, look, do I need to do anything with this or not? If the sergeant thinks, the amateur sentinel thinks, look, this is something which we never see, forget about it. There's no point sending out the troops for a three-legged green cow, because you're never going to find it. So it doesn't send out the policeman to look for a three-legged green cow. If he says, look Sarge, I've got a brick from a house, bricks and houses everywhere, there's no point sending they're everywhere. So it may be sampling your normal body self. It says, we don't want to attack that. There's this area in the middle where actually things are, you shouldn't really be seeing them, but they're there. So you've got the thief. The thief says, right, let's go after the thief and catch it. What happens in the autoimmunity is this system goes wrong. That bit of you is recognised as not being you. Now, your question about the vitamin D is probably where this, in my opinion, is where this comes in. Because in the environment of low vitamin D levels, vitamin D is the sunlight vitamin, yeah? Every week it's in the Daily Mail saying how it's going to cure this, that, or something else. Vitamin D, low levels, will upregulate these antigen-presenting cells. They become autoreactive, your body starts to fight cells. We see that in the test tube. If you have the vitamin D levels at a level which are replete and or even sort of high and normal, you can actually downregulate them. So, why not treat people with vitamin D? We did for years, it didn't work. We were using too low a dose. That mechanism is why I think vitamin D works in these conditions. There's evidence in multiple sclerosis. There's evidence in thyroiditis. None of this evidence is overwhelming. There's evidence in lupus, rheumatoid disease, Crohn's disease. There's no evidence in psoriasis, but I think it works as well. Because you tend to try and push this system back together and make it become function correctly. There are some families where they have a problem with these cells which control this. And the one that sort of is coordinating all of this is something called a TH cell, a T helper cell, which again can be in particular genetic predisposed families, predisposed to autoimmunity of all its flavors. Asthma, joint disease, bowel disease, all these different things. And vitamin D, I think, is helpful. You can actually check. It costs £600 to do that, to do FOXP3 testing, so we don't do it routinely. And it's still a bit experimental, but I think maybe that will be a future thing to look at.
So what was that, Fox?
FOXP3. It's a T helper cell marker.
So what dose of vitamin D would you need to do?
I use, the data is that 2,000 international units of vitamin D a day. There is some data on this. The Vitamin D Council of America reckons you have to take a much higher dose than that. You have to be slightly careful because if you take super huge doses, it can cause hypercalcemia. But actually, 2,000 a day, I have never seen a problem with that dose. Some people do get high levels of calcium, but it's for other reasons. And so there was some evidence that basically, if you sort of get all the studies and put them together, it doubles the chance of going into remission and doubles the chance of staying in remission. I'm taking that, thank you very much, and I do.
So 2,000 IUs?
Yeah.
The one a day tablets is 25?
That's micrograms.
Right.
Which is 1,000. 25 is micrograms, so 1,000 international units, 2,000 is 50 micrograms. I buy mine online because it's cheaper.
A couple of questions about vitamin D.
Yes.
One of them was that I heard that there are some rheumatologists that will prescribe it to every single patient that comes through.
Everybody, I don't check people's levels. Everybody's low.
Okay.
It says, I think it says, everybody says 30% of the country is D deficient. Well, I don't know or not, but when I checked people 15 years ago, everybody was below 30. This time of year, if you're not on supplements, you're going to be low. I think everybody should have supplements, to be honest with you. And I take it myself. And in other parts of the world, people are low. Now, vitamin D is a sunlight vitamin. But we live in the UK. What's up? I use a rule of thumb. If you put a stick in the ground, if the shadow is longer than the stick, There's no vitamin D again. You're not getting any vitamin D from the sun. But we go out, we wear these things. We're indoors. And what happens when the sun comes out? Whoa! Skin cancer! Sunblock. So we cover ourselves with stuff. And actually, we have I think we've over-egged the skin cancer problem. In fact, there's some data to suggest that the sunlight exposure will increase your risk of dying of skin cancer, but lower your risk of dying of everything else. So we got, you get particular groups saying you've got to do this, that, or something else.
My second question,
sorry.
is I was told that the 50% of vitamin D production is from sunlight hitting the whites of the eyes, and most people wear sunglasses when is that not something that you've come across?
It's the actual skin.
Okay.
The vitamin D is hydroxylated in the skin, which is why sunblocks, which block UV light. And vitamin D, we've been using it for years to treat psoriasis. Okay? People with psoriasis, you mentioned you have psoriasis, so I'm going to pick on you now, sorry. If you have psoriasis, skin disease, it's worse this time of year. The skin disease is better after you've gone on holiday.
I actually lived in the Middle East for 10 years.
Didn't have it?
Never wore a t-shirt.
Yeah.
There was a dive team, so run around topless
All
all
day.
day. Sorry?
I've gone off you.
I'm
jealous.
body for it then. Never had it. Came back to the UK within a year. Had psoriasis.
Yeah.
And then within 7 years had the arthritic version. In the Far East, and that's where the first lesion started.
Yeah.
And we're saying that's how it got in.
Probably not.
Right.
Probably not. Do you mind if we go? No. The hypothesis behind this spondyloarthritis is that it is an exaggerated injury response. That basically means if I'm walking along and I twist my ankle, it gets swollen for a couple of days. It gets better because there's an inflammatory process which gets switched on, and then there's an anti-inflammatory process which switches it off. In psoriasis, that system doesn't work, and that's mediated by chemical interleukin-17, which is one of the new drugs acts against. So your body responds by having an excessive response to an injury. So psoriasis, there's something called the Kerben phenomenon. People with psoriasis, you know what psoriasis is? It's a rash. You get a scratch, you get psoriasis of a scratch. It's an excessive skin response. But you can get the same thing in your joints and in your tendons. So we think this is probably an exaggerated response, and a bite may well have just aggravated, that was the starting point, because there was a local trauma which then had this exaggerated injury response. The other side of the coin of that, your immune system's better than mine. It fights things better. You are protected from HIV and hepatitis. Wouldn't use it as a protection, but your body is better at fighting those sort of things. There's a survival advantage, and it seems to be this is against those agents.
So is this why, even though I'm on immunosuppressants with the
you don't get cold.
I'm still not getting ill?
Yeah. People with psoriasis often say, everybody else in the office gets a cold, I don't. And that's because their immune system it's like overactive and kills things quicker. Right. But then they have this other problem. Sorry.
Haven't they just done a recent study on fruit bats who carry viruses but don't get infected by them because their immune system is actually very low, and so they're not having a big reaction, and therefore they're surviving. So their immune system isn't killing them. This was the study that was done.
Have not a clue, so I don't know anything about that. but don't forget, you can carry an infection, carry a virus and not be infected by it. So just because there are bugs in a particular thing. So for instance, there are malarias and mosquitoes. It carries an infection. It doesn't affect them.
This was a lot of viruses that they were carrying that would normally have killed any other animal, and they couldn't understand why the bats survived.
Couldn't answer that.
They
may well be they had immunity to those viruses, otherwise that bat line would have died out.
Well, yeah, but they reckon it's because their immune system wasn't up and fighting, and therefore,
Can't answer that, I'm afraid. I'm not a bat expert. Right, we've done those, the deformities. I like spending lots of money, so I do blood tests for my senior patients. So we do these immunology testing. Anti-nuclear antibody, rheumatoid factor, and this thing called CCP. Rheumatoid factor. Everybody gets very excited about rheumatoid factor. We all have it, first of all. If any of you got a cold at the moment, your rheumatoid factor is going to be positive. What is it for? Well, there are lots of different antibody types out there, but what it does, it binds, rheumatoid factor binds to other antibodies. This bit at the top here of an antibody, that is an antibody. Okay? That binds to something, it binds to a pen. But what the body picks up is the elbow. This bit here, the heavy chain. If there's a virus particle taken out, and one of these binds to that is not enough. It says, look, this is a three-legged unicorn, we're not going to attack this. We're not seeing enough of it. But what we get here is this starts, the rheumatoid factor will start to bind to these things, and you start to get more elbows. So elbows, sorry, this is going to be bizarre, but elbows will actually, is what your body's looking for. And that's what the other immune cells will gobble up and process this thing. And so rheumatoid factor actually sort of binds with itself. Right, can I have you three, please? Right, okay, so rheumatoid factor, anti-pen, that's a fine. Okay, that's not enough to hit my immune system. Right, you have an antibody against my wrist. Can you bind my wrist, please? No? Bind my wrist like that. There we go. Now we've got 2 elbows. Not enough. Can you do that one? Bind her wrist. 3 elbows. That's an immune complex. Okay, and it'll go on and on and on. But also, this does other things. Can you go each other's wrist? Like that. That's a rheumatoid factor dimer. Bind like that. 2 elbows. That will start to be produced, and that's what we're seeing in this situation when your body is fighting various infections. And then you can get another one where wrist, and there. There we go. You get 3 of them. Trimers. You get 4, 5, 6, and actually you can see this in electron microscopy. So this is an antigen amplification process. That is the only one thing there.
Sorry,
this
say that again more slowly.
antigen amplification. We see the pen. That's not enough to fire off the immune system, but we've got these elbows going on. We've got this and that binder here. And this is a lot going on. My immune system comes along and gobbles this up. And the way that it does that, if I go back to this, thank you very much, you can sit down again, wonderful. These things gobble up this pen, and they'll take the nib of it, and they'll put it there. And it'll say to this APC, there is an end of a pen, we need to fight it. And because your immune system is also being switched on by the rheumatoid factor level, then it starts to go. That's the normal immune response. Rheumatoid factor is slightly abnormal in these patients, though, and there's too much of it. And that is part of the immune response being overactive. Anti-nuclear antibody, everyone gets very excited with it. Everyone thinks you've got that, you've got lupus. To quote the TV show, it ain't lupus. Lots of people can have that. And actually that is very common in psoriasis. About 50% of people have antibody in psoriasis and causes some confusion. The CCP antibody is one that, have you guys heard of the CCP antibody? No? Okay, we'll come then. Rheumatoid factor, seeing with lots, this isn't a list which is by any means complete, but you're seeing lots of different things. HIV, the big mimicker, syphilis, that's your pirates stomping around, you'll all remember that now. But you see with lots and lots of different things, and other infections can do it as well. The CCP antibody is where part of an amino acid sequence is altered. It is very sensitive. It says here to rheumatoid disease, actually to joint damage. You see this with lots of other immune diseases as well. This comes back to the story of why do we get this? It's seen in rheumatoid disease in lots of people. Microbiomes again, bugs, interaction of bugs in your immune system. The CCP antibody comes from lungs and gums. That's what I tell my students. People who smoke get it. Rheumatoid disease is a smoking-related disease. Unfortunately, there's something in cigarette smoke, what it is we don't know, which activates the immune system, and if you've got the wrong genetics, will push you into rheumatoid disease. It causes a problem to lung. People who have lung inflammation for other reasons, such as bronchiectasis, get rheumatoid disease as well. They have lung inflammation. Bad gums, periodontal disease will do it. Periodontitis. There's a bug which causes inflammation around the gums, which will actually cause this antibody to produce on its own, despite your genetics. So bad teeth, both lungs and gums, and you look for these patients. And actually, if you have this antibody, you are on poor prognostic rate. You're going to have more damage, you're going to have more other organ involvement, it's going to be more difficult to treat.
So, when you spoke at the Spire, your final comment was, if you've got bad teeth, have them taken out. Is that why?
No, it's what they used to do in the 1920s.
Right, okay.
If you've got bad teeth, get them sorted out.
Right, okay.
And get the periodontal. I saw a lady this morning who is CCP positive.
Yeah.
She had grumblings going on, hadn't quite started yet. Her treatment was, got teeth sorted out. She's been in remission for a year.
Right.
And she's been on vitamin D and omega-3 as well. But that's all we did. We didn't give her any drugs. She just took away the driver behind it.
So what work did she have done? Just
She had a periodontitis treated. So basically her teeth properly cleaned,
yeah.
and the periodontal disease was treated. It's not just sort of gingivitis, it's it's proper inflammation. And then in the 1920s they used to take people's teeth out, which helped rheumatoid disease. Now, this sort of antibody positive rheumatoid arthritis, I don't think is a bowel problem. I think this is more related to the microbiome somewhere else driving this. There are still some patients who will tell you that tomatoes are aggravated. If they do, fine, they will avoid that. I don't find these patients respond so well to diet therapy. Seronegative rheumatoid arthritis, whether your blood tests are negative, it's coming from somewhere else, is most likely the gut. 85% of your immune system sits there. If the driver is a food or food substance, then can they avoid it? And that's when I look for those issues. It's difficult to get real data on this because people lie about what they eat. And actually looking at the microbiome in the middle of your gut is actually quite difficult because all you can really sample is what comes out, and that's not necessarily the same as you want to look at without trying to be too crude and put you off your dinner. So, what are the genetics? We know there's some genetic factors. HLA-DR4 used to be called the shared epitope. And we know if you've got that and you smoke and you're CCP positive, then you're going to have very bad rheumatoid disease. Even if you haven't got it yet, you know you will get it. It's a new world disease. I've mentioned the Pima Indians. Tobacco. It's probably not just tobacco, but I had a couple of years ago, I had 3 guys who worked on burger vans. You know, the ones on the side of the road. They all developed CCP positive rheumatoid disease. None of them smoked, none of them had bad teeth, and my only reason I can see they got it is because they were leaning over this carbonised stuff and breathing it in. Certain foods may be a factor here. Tomatoes, potatoes, there's a song there somewhere. Estrogen, sorry you guys, girls just screwed, and the teeth, as I said. And there may be other factors we don't know about. These are things that may trigger this disease. To get rheumatoid disease, it's like being shot with a bullet. I need a gun, that's my genetics. I need a bullet, and that's my environmental exposure. And then something pulls the trigger. And that's the infection, the stress event, the pregnancy, death of a parent. Something comes along which fires the trigger. And stress is a trigger for this condition. And will actually make it worse. It affects other parts of the body as well. Eyes, we mentioned all these lungs, lung involvement is very common. If you're positive as well, you're going to have a lot more of these things. Fibrosis of the lungs, always associated with poor mobility and poor mortality rate. Nerves everywhere in the body can be affected. Brain as well. These patients all got depression. I did a study on this a few years ago. 85% of our patients who are in remission were depressed. That is because they've got a disease which is uncomfortable, it's because they don't want to have the disease. That's probably because they're seeing me, but also there are inflammation markers on the brain which actually cause depression. And there are some studies that show that if you have people who are depressed on raised inflammation markers, you treat them with biologics, their depression gets better. Because depression may be is a biological disease. They get dry eyes, which is Sjögren syndrome, either primary or secondary. The eyeball itself gets affected, actually melts the eyeball. These will actually dissolve, and the inside of the eye, the vitreous humor will actually fall out and will kill the eye. And then if that happens, there's a very high chance the other one's going to do it. And these patients need chemotherapy. You're going to save their eyes. Eyes are a strange beastie, they're difficult to treat. It affects the lungs, you get inflammation in the lungs. So I'm realising your food's going to be here soon, or you're going to have a little break. It affects the lungs, it affects the heart, the heart gets squeezed. There's a sac around the heart like a skin. And it does this, you get this fluid in there, and if you actually take that off, you've got this stuff which is very thick and viscous. It looks actually like tuberculosis. And it squeezes the heart, and the heart can't beat properly. It doesn't pump blood, and you get right-sided heart failure, and if left untreated, the patient will die. Response to steroids doesn't respond to a lot of our other therapies until the biologics came along. The next, just be aware, the only one thing I'd take about today, be careful of necks if you've got people. You know this, don't you? Next, back to axial subluxation. We don't see so much of it now. Bad hands equals bad neck. But the other entrapment neuropathies as well. Carpal tunnel syndrome is very, very common in these patients, particularly when the wrist is swollen. Rheumatoid nodules. Sometimes drugs make it worse. These are pressure points. And actually these are always seropositive, these patients. Always, always, always. And you see that, you know, sometimes this is likely to be rheumatoid disease. Gout can mimic it a little bit, but if it's there, it's likely to be rheumatoid. That is one of the few things that the patients will show outside the joints will not increase mortality rates. It's just inconvenient. I've seen people where the glasses sit, where the rest of their elbows, back of their heels, where their shoes are rubbing, on their knees if they're near it. So they can get nodules, and some of the medicines we use can make it worse. Vasculitis, inflammation of the blood vessels. You don't want this one. This is the one that actually starts to cause problems, and you can get hemorrhage into the lungs. You can damage all parts of your body. The immune system is carried in the blood vessels go everywhere. If these blood vessels start to stop, it's going to infarct, it's going to kill bits of it, which is what's happening here. If this is in the periphery, this could be happening somewhere else. And you can lose fingers, you can do, that can happen to bits of brain, bits of heart, bits of lung. And it's really rather unpleasant. But I'll give you all the bad news. We've got some good news as well, which is things are working. We're diagnosing it better. I'll get rid of the old criteria. The old criteria for rheumatoid disease was a bit rubbish. We've got a new criteria, which basically means you just see how many points you've got to get 6 points. Why is this not doing something? It's not plugged in. Okay, that's why you want to try and kill itself. I won't go through that, just to say that predominantly we score the small joints. The more points you get, the more likely you're going to get rheumatoid disease. We want to diagnose these patients early. If you've got positive immunology, increases the chance of having this. If you've had it for more than 6 weeks, increasing it. You can get this transient joint inflammation, response to infection. If you ever had a viral infection, you've had a rash on the skin, imagine the rash on the joints. But then that should go away. If it doesn't, it's going to be something that's persistent. Acute phase response, and this is the EULAR criteria. You've got to have 6 or more points for definite rheumatoid disease. But you know what rheumatoid looks like. We work them up, we do lots of blood tests. I do this, I do ultrasound. I do this, all these patients coming in. Ultrasound for me has revolutionised what I do. I can see people, I can make a diagnosis, I can tell them what's going on. This is inflammation around here. This basically shows movement of red cells, shouldn't be there. That is burning a hole, drilling a hole into the bone. I can tell people they're going to have erosive disease and they need to start proper treatment now. And patients love tech, don't they? Don't they? You get something that you've got screens and buzzes and makes funny noises, they love it. And they love saying that. And also it helps to sort of reinforce what I'm saying, because otherwise you send people for x-rays, they come back and they feel it's slightly divorced from what's going on with them. You can show them straight away what's going on. You get more buy-in there. and it's tech, and they love it. We take the fluid out. These are neutrophils. You don't want those in your. If that's in your the fluid in your joints, it means there's inflammation there. You don't want that. We do X-rays. This is sorry, that really doesn't show very well. The carpal bones here in the hand, they dissolve. And what happens is they just get smaller. So you can imagine then your tendons loosen and things drop. And they flop around because they don't work properly because you've taken my hand's gone from that to that. So my tendon pulls and there's nothing to pull. It doesn't work either. We don't want to see this anymore. And actually, new patients now should not get this. If they get this, in my books, if they get this, we failed. It's in their feet as well. First joint effect is this one here, the 5th MTP joint. So these are the ones I looked at with ultrasounds. We treat them anti-inflammatories for stiffness, corticosteroids of huge side effects, but of immense utility at the start of this condition, and standard DMARD therapies. And I put vitamin D and omega-3. Study done in Adelaide just over 2 years ago. Omega-3 given to 25 patients, omega-3 not given to 25 patients, otherwise treated exactly the same, twice as many went into remission.
Again, what sort of dosage?
I was hoping you wouldn't ask me that, because the dosing for that was 3 teaspoons of fish oil a day,
Right.
which nobody in the study could take because it was hideous. And so they say, oh, we've got to take those. I actually use a cardiac dose, which is 1,000 milligrams a day. Possibly not enough for rheumatoid disease, but it does seem to work. The 1,000 milligrams a day is the one that halves used to cardiovascular disease. Study from Oxford last year showed that. But we use lots of other things. Methotrexate, chemotherapy drug. Most of our patients get this. But it is to chemotherapy as half a shandy is to a bottle of vodka, which is a low dose. We use up to 25 milligrams. Chemotherapy dose is 1,000 milligrams. But we do have to make sure that we don't damage our patients with these things. These drugs all have side effects, so they do need regular monitoring. Increase the risk of infection slightly. They all have pros and cons. But I'm actually using methotrexate to treat wear and tear in little old ladies. That is safer than ibuprofen. And it works for osteoarthritis for a lot of people. Not for everybody, but for a lot of people. So our room for Imagine now is we want to treat people early, treat hard, minimise disability, minimise mobility, minimise mortality. There's a lot of data to show that that works. And this graph will show if you treat early. This is the early treatment arm. This is a damage, X-ray damage score. Forget it. Basically, how it is or worse it is. If you treat early, and this is just drugs we wouldn't use anymore because they're too mild. But this is treating early. This is within 3 months. You do that. If you delay it for 3 months, you do that. Earlier better. So if you guys see somebody with rheumatoid disease, you think they may have it. It's just started. Don't sit on them. They go. Unfortunately, you're not allowed to refer into our NHS practice. You're not allowed to do that, which is nonsense, but unfortunately, it's not my rules. If you see that, you've got to get the GP to refer the patient straight to it, because we have a time window to treat this patient.
That exact case has just happened to me, whereby I had a patient that I suspected had rheumatoid disease of some kind, referred them to the GP. And the GP has then referred them to rheumatology.
Yes.
They found heightened rheumatoid factor,
Yeah.
but haven't really, they said we need to do another blood test in sort of 3 months' time or something. So it's left untreated.
Unfortunately, sometimes things are a bit bollocked, aren't they?
Yeah. And it's naproxen, I think.
That's probably me, wasn't it? That's why I do ultrasound.
Oh, and that's what you were saying. I was thinking
But most people don't do it. Most people don't do the things that I do. I've spent years trying to do this, and I've realised that my clinical skills are rubbish. I haven't a clue what's going on inside the joint. If you scan it, you think somebody's in remission, they're not. You think they're active, they're not. And
those blood tests, sorry to interrupt you, do those blood tests need to be taken whilst she's having a relapse?
No.
So they could be taken,
No.
because I think that was the theory behind the 3 taken
the blood test that will change will be the inflammation blood test. The ones that don't are the background immune markers, which is the rheumatoid factor, and that's CCP. They may be talking about the CCP blood test. What I'm running at the moment is a trial at Mason Hospital, looking at using one of the drugs we used right at the end, before people even got the disease. Somebody went to the picture study using abatacept right at time minus the disease. Can we stop it from starting? And we haven't analysed the data, so I can't tell you the answer to that. My feeling is you probably can.
So sorry again. So would your sort of first input for us as a sort of term for us to kind of refer on what we do, refer to the GP should refer to rheumatology, who should then be doing bloods,
GP would ask GP to do the blood test.
Ultrasound?
If you've got somebody who's got obvious synovitis, joint inflammation in the joints, ultrasound may not give, I mean, I would do it anyway, but I'm a bit sad about that, so I like toys. Would you say, would it actually give you much more evidence of things going on? I think it does, because you look for prognostic markers. And those prognostic markers I'll come to in a second. If I don't hang around, if I see this, I treat it early. And I tell my patients there may be a degree of over-treatment here, but 70% of my patients go into remission, which is about the best, it's like the second best in the UK.
So if I have a friend with rheumatoid arthritis and she seems to be sort of very poorly controlled, what sort of quality of life, if you're going in there and you're kind of putting them on methotrexate straight away, what sort of quality of life would they be having? Would they be in remission symptom free, or?
My target for my patients is disease remission. Remission is defined as absence of, certain ways of doing it, but basically no tenderness of arthritis. Now, if somebody has got established damaged disease,
that's not going to change.
That's not going to happen. If somebody's got wear and tear and lots of joints, they're not going to have remission. And they're into pain remission because they're going to have damaged joints. The picture I paint for the patients is that their house is on fire. I'm a firefighter. I'm coming on with my hose, I'm putting the fire out. Okay? If it's just a small fire in the kitchen, I'll put the fire out, and then happy days, the house you can live in. If the kitchen and the dining room and the living room are burnt out, I can put the fire out, but they've still got a damaged house, and that's what orthopaedic surgeons and the builders can come and repair their bits. But what I do is I say, one of the reasons I overtreat is because if you're a fireman, you come along and just squirt some water on the fire, goes out and go away. 6 hours later, the fire starts again. You've got to keep dousing it to put it out. And that's what we do, we hit it hard. We use these things, combination therapies. I use a lot of them. In fact, last time we checked at Mason, which was a few years ago now, we had 67 different combinations of things we use. They've all been shown to be superior to the individual treatments. I want somebody in remission. I see them. Are you in remission? No. What are we going to do about it? Do you know what? I just don't feel like taking excuse. No excuse. You're not in remission. We're doing something about it. That study from Glasgow was pivotal, and that's what I use, and that's what I base my practice on. You're not in remission. What are we going to do about it? And that says lots and lots of people go into remission. These are DAS scores. These are disease scores. That is remission criteria. These are the median scores. Intensive treatment, not intensive treatment. Seeing the same people. Eventually, they actually were all on the same drugs, but these guys got hit early. Are you in remission? No. What are we going to do about it? That's what we should be doing.
So you don't really have a place for kind of conservative treatment of, we'll wait and see. And
there are some people you can, because you can try and risk stratify the patient. If your blood tests are all negative, if your inflammatory markers are normal, if you don't have any joint damage, there is an argument to say that your chance of getting damage from this condition is very low. So, and some people say, I don't want therapy. You say, okay, fine. If somebody's 85, you may say, okay, we will perhaps be a little less aggressive with this therapy. But by and large, if anybody in this room came to see me with acute inflammatory arthritis, I would treat it like a cancer. I'll smack it. Remission induction, remission maintenance, get you better, keep you better, and then withdraw the therapy. That is the line that people want to hear. And that's what I'm doing now. Getting people down. But I'm a little bit like the cost of petrol in the petrol station. I go up like a rocket and I come down like a leaf. So I'll go up very rapidly, the steroids will be off quickly, But the other things will take, I normally come off, I want people in remission for a year and then I slowly reduce. And I want to keep people in charge of this. You feel your disease is coming back, you put it up yourself. Let us know, do it yourself. You or I'm in charge. Because these patients, when they come, when they're here, they're a rabbit in the headlights. They are terrified. They feel like they're a leaf blowing in the wind and lost control of their lives. You've got to give them that control back. And actually the reason I think my clinics work so well is not because of me, it's because of our clinical nurse specialists. I don't think we've got the best doctors in the country in our trust. I think we've got the best clinical nurse specialists in the country. I think they are absolutely brilliant. And actually they're the ones who will support all this. And they said that, I always start, I'm at the diagnosis, I get the easy bit, I'm at the diagnosis, okay? And then the nurses actually sit on the patients and see them very, very frequently. Once people in remission, do you know what? You're better, I'm not interested, because you're better. The nurses will support and do the other activity. And that's what they're very, very good at.
But then going back to the blood tests, how reliable is the rheumatoid factor?
Rheumatoid factor is positive in 70% of people with rheumatoid disease. And the C6 antibody is seen in about 60 to 80%, depending what study you look at. So there was a subgroup who had negative blood tests, but will still have rheumatoid disease. It may well be what we've actually done is misdiagnosed it. It may be they've got psoriatic arthritis, but they don't have the psoriasis yet. So you've got to keep your mind open. What other condition could this be? And you know there are some well, a lot of other conditions like that which will mimic this condition. So seronegative, I keep my eyes open because osteoarthritis can do a lot of this. It actually will respond to methotrexate. And that will include, is that a seronegative inflammatory arthritis? It is, it's not rheumatoid disease, but they often get mislabeled. So what do we get? It's not all about drugs. That actually should be up there, education. I need the patient to know what I'm doing. I encourage them to use the internet. I give them websites to go to say, please look this condition up. I want them to know why I'm doing it. I ask them to say, if you don't know what I'm doing, you challenge me. If I can't explain to you what I'm doing and why I'm doing it, I shouldn't be doing it. Now, with these things about the vitamin D, I have to say to them, you know, data's not great, but have a look and see what you think. And virtually everybody takes it. Stop smoking. If that started this disease, you keep smoking, you're not going to get better. So I say, going back to the house fire, I'm trying to put out your house fire, you're throwing buckets of petrol on it. I'm going to struggle. Obesity, if you're over 100 kilograms, you don't respond to well to therapy. Fat tissue drives inflammation. And actually a lot of our seronegative patients actually, I think, have probably got a condition I'm now calling obesity-associated arthritis. They have raised inflammation markers, they have inflammation in the joints, they're seronegative, and I think they're all at very, very high risk of diabetes. Because diabetes is due to insulin resistance, and some of the chemicals from fat tissue are predisposed to that, particularly leukotriene B. And complementary therapies. I encourage people to look after themselves as they wish to. The only things I will not let them do is Chinese herbal medicine. If any of you believe that, I'm very, very sorry. I've seen too many people damaged. But complementary therapies, these people will go see, sometimes will see a reflexologist. And they say they feel better afterwards. Because they do feel better afterwards. I think it's the relaxation that's really important. If your people are stressed, it's pro-inflammatory. People who are relaxed, it is anti-inflammatory. There's a lot of animal studies and there are some human studies that will support that hypothesis. And we've got lots of biologics as well now. Because I am very, very expensive. Of all the drugs prescribed by hospitals in the country, in the UK, I prescribe 3 of the top 4. Humira, Enbrel, Infliximab. Last year, 2012, this country spent £350 million on Humira, one drug. Your fault.
It's great.
It's great.
I'm actually Enbrel, but...
okay. The second one was Enbrel. This country spent £250 million of it. These drugs have revolutionised this condition. These people have gone from being crippled, disabled, unable to work, to being functional, working, back in society again. If the house has been burnt down, they don't work. But people's houses don't burn down so much anymore because of these drugs. These are brilliant. When I first started doing rheumatology years ago, we used to bring people in for a week, and starve them for a week. We injected 30 joints in one go. And these people are happy just for a week or two of not being in pain. Patients would not accept that these days. Good. These things work. And they work on lots of different chemical pathways, and these are the ones that are out at the moment. But there's thousands of different pathways out there. National Institute for Clinical Excellence can't keep up with the new things coming out. And actually the UK now are behind the rest of the developed world, because we can't use things that the rest of the developed world can use. Patients don't have to pay for these drugs. The biologics cost a lot of money. Things like Humira are over £9,000 a year. Things like tocilizumab, pop treatment dose is about £15,000 to £20,000 a year per patient per year. So I'm expensive. Okay. It is 25 to 9. Do you want to have a little pause?
We'll break and we'll come back at 9.
Okay. What I'll do, I'll just finish off this bit here. I'm just going to do 5 minutes just to finish this. I'll go to any questions and then I'll do a little bit on hypermobility if you wish. Although there's not huge amounts to talk about hypermobility, I can really tell you. Back to rheumatoid disease. We use these biologic drugs that I mentioned. What I'm going to tell you, a lot of the slides here, they all say the same thing. They work. They have changed people's lives. But they cost £10,000 a year. And the problem is, in this country, we have this construct called the National Institute for Clinical Excellence. Yeah, nice. You've heard of them? Lovely people.
But I thought they valued people's health at 24k a year.
That is one collie equals £20,000 a year.
Sorry, one what?
Quality of life years is an artificial construct by the people on the NICE committee. Basically, you say how much you can improve and how much they're going to spend on money. There is, in this country, if your disease level is here, you can get biologic drugs. If that is remission, you've got to be up here. There's a lot of people in the middle. The rest of the developed world, it's there. So we've got a lot of people in this country who are struggling. And that's because of NICE. The difference in this country is people do not have to pay for the drugs. In the United States of America, two-thirds of all personal insolvencies are due to healthcare costs. These drugs are expensive in the States. Actually, NHS actually gets quite a good deal of these things, to the extent that actually there was one of the trusts on the south coast were a bit naughty a few years ago, and they got a very good deal in NHS, and they flogged these drugs to the French and made a profit, which is a bit naughty. And they got there. They made about £5 million in. So these drugs work, and they will work where the standard tablet therapies don't work. People feel better. Do these drugs work? So you're my expert patient now.
It's life changing. I've gone from suicidal because I've had enough.
Can I use you? Okay.
So I just think, why are they so expensive?
I'll come to that in a second. Right. What do you mind? You might do this. You're big Phil. Do you mind that?
That's all right.
No? Okay.
Someone's going to watch you, though.
Before you went on the biologic drugs, how was your condition?
My wife, if I started work at 9, I had to wake up 2 hours early so my wife could help me out of bed. I used to crawl on my hands.
So, how old are you?
41.
Okay. Young bloke, should be in prime of health. Yeah.
I used to have to crawl on my hands and knees from the bed after my wife helped me get out of bed, crawl on my hands and knees to the bathroom, just have a wee in the morning. 2 hours of trying to mobilise my joints just so I could move. I was taking a packet of ibuprofen a day just to get through the pain, and like ibuprofen gel, and just plastering on my leg because my ankle was so swollen. It was drugs, it was painkillers.
How did you feel yourself?
Then,
Yeah.
suicidal.
Okay. People with suicidal numbers, first of all, it really hurts. If you ever, ever twisted your ankle, imagine every single joint in your body doing that. It's good, and the inflammation affects the brain as well.
That's what I could not think. It was like I was, yeah, I mean, not stoned, but just I couldn't focus, couldn't think. Really not sharp like I used to be.
Easy to ratchet.
Thanks.
And then somebody gave you a biology drug, and the Chancellor Exchequer spent £10,000 a year on that therapy.
Yeah.
Money well spent?
They told me that the drugs would take 3 months to work.
Yeah.
Now, because I'm a bloody minder, I spent the whole time questioning everything. Started changing all my diet, cut out so much. They told me 3 months before the drugs did anything. I did the first injection on Wednesday night. The following morning, it was the last day I took painkillers. And that was out of habit.
And how did you feel?
Like I did 3 years before. But it was life changing.
Some people are almost resurrected with these drugs.
Yeah.
And that story has been replicated time and time and time and time again. 20 years ago, we didn't have these drugs.
When I got the diagnosis, stress is a horrific one. They told me my hands were going to end up just clawed and I was going to make a wheelchair. It's the worst news I've ever been given. For where I am now, still working, young family, kind of happy.
Awesome. Well done. Thank you very much. That's what these drugs do. Thank you for doing that. My patients are different now to what they were 20 years ago. Before these drugs appeared, the only thing that really worked, if you did, because we had an old paradigm, we treat people low and slow. We never got on top of it. The house was on fire. We get the old bucket of water. Oh, it's not quite doing it yet. Oh, we got not enough of the ground floor's on fire, so we're not going to try and put it out. Well, the paradigm's all wrong, and it's changed, and I'm very grateful for that. Unfortunately, rheumatologists are a bit of a strange beast, and some still haven't quite caught up. And there's lots of different ways that people function. I've come to the conclusion is, if I had this condition, I would want to be treated by me, because this condition is not. This is why I don't like the term arthritis, because people think, oh yeah, this is granny's disease. This is not. This condition makes you feel terrible. It actually shortens people's lives. It damages them. You wouldn't have functioned much longer like that. And you can understand what the suicide rates were with people in this situation are very, very high. We can deal with these conditions now. These drugs work. They don't work for everybody, they work for 70%.
What about juvenile arthritis? Can the juvenile brain be used in that?
Yes, they can. There are different forms of juvenile idiopathic arthritis. And these drugs some of the drugs have a license for these in children as well. You try not to use steroids in children because obviously it affects the growth plates and may impair growth. Children tend to go onto injectable methotrexate early, and they tend to get onto these drugs if they need to. And these drugs are transformed these children. They get back to normal life. Not for all of them, but for most of them. In fact, in troubles in Kent, we don't have a paediatric rheumatology service at all. These children are looked after by paediatricians, or they have to go up to either the Evelina unit or to Great Ormond Street. Because I'm not actually allowed to treat children.
Do the children have to stay on it forever, or what's...
Actually, interesting to know, there seems to be this sort of cut-off. Most children tend to get better. And I use a cut-off of 17. Most kids will get better, but there's a hormonal influence here, and often the different forms. Some of the forms of inflammatory arthritis start when you're very young. So the one which just affects about sort of 3 or 4 joints tends to start when you're about sort of 3 or 4. Some may start when the rheumatoid arthritis may start when the hormonal start kicks in, so sort of 11 or 12. But it does vary. But often it burns itself out. There is a subgroup of what they call it juvenile idiopathic arthritis, which we call Still's disease, which is a different beastie. This is something called an autoinflammatory disease, and that's really nasty. You just need to jump on it hard. And it's not, joints get inflamed, but it causes lots of other problems as well. Yeah, so these patients can do well. Children do it just as well, but the drugs are expensive. So that's what all our taxes pay for. I just realised I can't spell, can I? So I'll get rid of that one. These are the scores. These drugs don't just work on symptoms, you actually stop the joint damage in rheumatoid disease. Sorry.
So, quick question, and apologies if this is one for you. Obviously, they're really expensive to produce because of the production methods and all that kind of stuff. How far away are we from having the biosimilars? Obviously, I know that there are various companies in India who are coming out with them.
Okay.
They work.
Biologic drugs work. These aren't drugs as an aspirin is a drug. A biologic drug, drugs like aspirin sort of interfere with a chemical process. A biologic drug actually augments or antagonises a normal process that's in the body. These drugs are expensive. They are expensive to make. An aspirin is a small molecule. If an aspirin molecule was this cup, Humira would be the size of this room. They're exceeding, and they are a construct of an antibody. Humira, for instance, is what's called a monoclonal antibody, and you genetically engineer. In fact, Humira, I think it's a mouse ovum, and it produces this stuff, and then you have to purify it, and then you have to purify it again, and then again, and then and again. It's a very, very expensive thing to do. About 10 years ago, Enbrel, which is another one of these drugs, they had one factory in the world making stuff, and they buggered up one's treatment cycle. They lost 3 months treatment for the entire world. These drugs are expensive to make. The biosimilars, they are out already. There's some concern about them, but they're out. They have reduced the price by about a third. But they're still very, very expensive to make. They're not an aspirin. These are complex molecules which are proteins. They're all built together. And if you imagine this room is Humira, if I do that, the drug could kill you. I've just turned that over. And there was one example of this with an etanercept biosimilar, which never got out of study on animals, fortunately, where they put one sugar molecule in. And rather than helping you, you destroyed your bone marrow, if you're a mouse. So it never got into human studies, for obvious reasons.
The other side of it is, it's cheaper to spend 20 grand a year on me than me not working, going on to benefits, having my rent paid, everything else, joint replacements, and possibly 20, 30 years of treatment. Yeah.
But it's a different budget. The NHS lives from 1 year to year budget. That's the problem. I would agree with that. Yeah. I would have a very different treatment paradigm for all these conditions if I ruled the world. Yeah. Luckily for you, I don't. I would treat these patients right at time zero with a biologic. Yeah. We've done a lot of studies, pharmaceutical studies, doing that, showing it works really, really well, and it actually, over the course of the patient's sort of disease lifetime, it would probably be a cheaper and better thing to do. But we're not allowed to do that.
Because there were private insurance companies cover that.
They have. Not many do, but some do. I've had a few who have been allowed to give rituximab, which is a monoclonal antibody, which is an anti-cancer drug, which is one of the cheaper ones, which actually pops the cells which make the antibodies. And I've been allowed to use that in a few patients. But even that is £5,000 for the two drips. So normally they say no. But we've had a few in the last year. We've had a few, some of the private companies said, okay, we will let you do it just this once. Yeah, maybe. But I'm actually asked the CSU and the CCG, the Clinical Support Unit, and the Clinical Commission groups, if we can actually have people co-paying for these things. And there is this sort of feeling that perhaps that's not a good idea because it is not the NHS principle. But the thing about the national, sorry, please don't broadcast this too much, I'll get shot. National Institute for Clinical Excellence is about populations, not about individuals. It's what, with the money you've got, what is the best treatment for a population? It's not what's the best treatment for an individual person. People ask me, what would you do if it was you? And I have to be honest, I would take out a loan and apply this biology. They ask me that, because that's what I would do. Because I've seen the data, I know it works.
I suppose in terms of nice guidelines as well, if you're providing your patient with aspirin, steroid for a while, those costs have got to add up over a year anyway. Aspirin's a penny a tablet, steroids are a penny a tablet, methotrexate is £30 a year. Humira is £9,180 a year, and that's the NHS cost, plus all the stuff that goes along with it, with sharps, beans and all the other stuff. Plus VAT of 20% on top of that if you don't do it right. But these drugs work. They stop joint damage, they stop erosions. In rheumatoid disease, they don't do it in ankylosing. Actually, the spine will still fuse. When you see these patients with ankylosing spondylitis on biologics, they still got to do their back exercises. In fact, there was some thought that actually it may encourage these biologics, may encourage the spine to fuse in ankylosing spondylitis. So you've got to get people moving. This isn't the cure for them.
How did they get to these drugs if they're so complex? How did they think they were going to work on them?
There was a very brilliant man called Tiny Maney, who worked at Imperial College, who is now Sir Tiny Maney, who discovered these molecules in the early 1990s and very rapidly realised there was something that could be used to treatment. And very quick, from discovering these molecules to actually having a drug that worked and hitting the market was only 8 years, which is phenomenally quick. There was a huge concern when they came out that we were going to kill people with these drugs. TNF is tumour necrosis factor alpha. If you block that, these people are going to die of cancer. They don't. We've got registry data showing it doesn't happen. They're all going to die of infection. Infection rates do increase, 5 per 1,000 per year. But really, that's not a huge problem for these patients. In fact, actually, we're seeing a reduction in cardiovascular mortality in these patients from these drugs. The big thing is the cost. That's the big blocker from being used.
So is it a postcode lottery as to whether or not you will get these drugs?
No, because NICE have produced a guideline of when you can use them. You've got to have a disease activity above a certain amount before you can get access to them, and then if you hit that level, then the CCGs have to fund it. That's what they say. What NICE was supposed to say was actually, at this level you have to fund it, but you can fund it below that, but they will not say that. So there's a lot of people, if we actually look at the, so that is bad disease, which you're looking at it, that's remission. There's a lot of people in the middle. We know that if your disease scores about here, and rheumatoid score was 4.1, you're going to end up here sooner or later. Yeah. And actually in France you have earlier access to these drugs. But in France, they have the same number of people on these drugs as we do in the UK. It's just in the UK we get them later. So we've let the fire burn longer.
So we've got more damage anyway.
Exactly. So it's going to be expensive long term. And actually there is an argument, and actually the data supports, if you hit these people right at time 0, you treat them at time 0 for a year, and then you stop the drugs. You can't do that. It's all about budgets. But if it was me, that's what I would do. If it was one of my own. When people ask me, what would you do? And there's a lot of people with a lot of money who say, what would you do? I say, fine, here's a check. And so we're trying to see if we can actually get into the NHS side. Can we do co-payments? There's some antagonism towards that. But there has been precedent with co-payments in the oncology side. So they're looking at that at the moment.
Co-payments between the patient and
yes. So you can actually, if you've got a cancer, you can be on NHS care and say, actually, I want randomizumab, which works for my cancer. You won't pay for it, but I will. That went through Parliament a couple of years ago.
What sort of percentage split was that co-pay?
Sorry?
The one you're referencing.
I couldn't go in our trust up the road. Only 3 patients have done that on the oncology side. It's not much advertised, I have to say, but it is something which is it is there, and actually there's precedent. And I think there's people are going to be pushing more and more to do this to save money. It's all about that. It's all about the filthy lucre and this year's budget. So what is the problem? That's the problem with biologics, as we just said. That's the major thing. And not just in this country, around the world. Our department spends £6 million on biologics a year. So we're responsible for that budget, and we have to be careful with it. There are infection risks, particularly with these jobs. We look, tuberculosis increase, MS can happen, malignancy, probably not, but it's on the list, or we tell people it's unlikely to happen. The big issue is it doesn't work. Pregnancy, probably you can be on the pregnancy, but you have to be slightly careful. There's a jury's a little bit out, but I would actually let people be on biologics up to the second trimester. There was one, the reason we don't do it all the way through, there was one case report, and this is where you have to get to this sort of data of a woman who had Crohn's disease and infliximab all the way through pregnancy. She had a baby who was a beautiful, bouncing baby boy. When the baby was 6 months old, he had a BCG. BCG. Actually, he got BCG septicemia and died. So, we don't want to use this in the last part of the toilet. There was one possibly you can say you can. That is very, very, that's one case in the whole world. But these are the things that worry people.
Sorry, just a quick personal one. Biologics and male fertility, or any issues there, or?
No, are there? Not at all.
Everything's working, but
not at all. Not at all.
So it won't affect.
Not with the anti-TNF drugs. We've done some of the other things we don't know. Probably will be absolutely no problems. Or with some of the tablet therapies we use, there are some we wouldn't want to get pregnant on. Get father children.
Could you just go back to the previous slide? Thank you.
Oh, sorry. Okay. So did you get that? Yep. So rheumatoid disease, multi-system, lots of antibodies, lots of things happen. We can treat it. I need these patients early. I want to put out the fire when it's just a chip pan, not the whole downstairs. And actually, you are my eyes and ears for these patients.
Not being funny though, half time is getting them through the GP and out the other side.
Yeah. The GPs know this. I talk to the GPs about this as well. Unfortunately, some GPs are more receptive than others. And we actually part of the national. We did the national rheumatoid arthritis audit data thing last year. The big problem that we had was that actually it was the biggest delay was the delay in this region was that patients even going to see their GP with the problem. And then there was the next delay was the GP. There were a lot of delays in the system, which was probably avoidable. Some of it's about patient education, some of it is about GP education, and I've talked to the GPs about this. This is why I want to come out and talk this stuff, because we have a degree of we have a time window where we talk about plasticity of the immune system. We can change the disease course. Again, I use analogies for patients because I find that useful. Is if you're a big oil tanker, you're coming out of Southampton Harbour, Southampton docks. If you change the direction when it comes out of the docks, rather than getting to New York, you're going down to Rio de Janeiro. If you try and change the direction 3/4 of the way across the Atlantic, it's much more difficult to get out to Rio de Janeiro. That bit you do at the start, if we hit this paper at the start and we use steroids right at the start, no matter what you do after that, you will change the disease course. It will be less severe. Got to whack them early.
You said that there's not enough rheumatologists. What's the wait list? Have you actually managed to get a GP referral?
If he comes in saying, this patient has got, if the GP says, this person has got a new onset polyarthritis, I think it's rheumatoid disease, we're supposed to see the patient within 3 weeks, actually we're seeing them about 5. Which is not good enough, but it's better than it was years and years ago.
Is it worth the patient self-paying for that initial appointment and then going?
Through personal experience, I got my appointment through the rheumatologist. It was 18 months.
That was years ago, wasn't it?
That was 2 years ago.
18 months?
Yeah.
Where was that?
Hastings.
Hastings, Eastbourne and Hastings, for rheumatology have been in a particular state of meltdown, I have to say.
So I found out who the rheumatologist was locally,
Yeah.
a guy called Andrew Paul.
Yeah.
Found out where he worked privately,
Yeah.
phoned up his receptionist Tuesday morning, saw him Tuesday night, cancelled my clinic, saw him 2 weeks later, again privately, saw him on the NHS 2 weeks after that. So,
Yeah. Certainly patients that
that's
have
my
done it
own
enough for other
experience.
patients, it's
Hastings and Eastbourne have been a particular state of meltdown for a lot of rather complex, reasons, some of which are political. But actually, we're struggling to fill jobs in. I'll go off a little bit of a rant now. I've given up with recording, I don't know. We cannot fill consultant posts in the NHS. People are leaving, people are emigrating, we're not getting the fund doctors coming in, and we've got multiple posts now which are empty. And it's getting worse. And you know, you've seen all the stuff in the news, well, that's what's happening. And it's not just in medicine, it's in education, it's in the police. You know, people don't work in the public sector anymore. I'm lucky, I'm allowed to go and work at the Spire. Okay? I'm allowed to do that. I'm fortunate I can do that. I can get out. The NHS is imploding. And the news, what you see in the news doesn't do it justice. Things are hidden. But you know, you all know that. Because if it was working, you know, you guys probably wouldn't have a job.
Now it's probably like a bit of a basic question. So, the patient presenting to you with a classic sort of multiple joint involvement, morning stiffness, worrying. First point of call would be for me to refer to the GP for blood tests, yeah?
No.
Not now?
No.
You'll go straight
I would say, dear GP, GP, you've got patients got an acute polyarthritis. Can you do the necessary, please? And we ask them to do the blood test, but don't wait to get the results, just send them to us.
Right, okay, so we say to them, can you do an x-ray?
No.
Or, did you say?
Just send them to the rheumatologist department.
Just send them to the rheumatologist?
Get these things done in the interim, but don't wait.
Right.
Because those blood tests may be normal.
So ask the GP for referral to the rheumatologist?
Yes.
Straight away.
Can you do a referral straight away, please? Thank you very much.
what are the best words to get the patient to say when they see their GP to get to you quickly?
A script would be brilliant. Well, they don't go to...
What words to get the hell out of GPs?
G, M and C. Basically, well, what they're worried that most GPs will practice defensive medicine. They're very scared about being sued. There are guidelines for these things. What they should know, and they do know, is that these patients need to be referred very rapidly. Some GPs will know more. The thing is, the ones that know this stuff, you won't have to wait with.
Yeah.
It's the ones who don't know. And actually, there are people out there who are doing a locum, they don't know how the service works. They come in, they only do they work there 1 day a month or something.
Yeah.
It's difficult to know that. You just say, I think this patient's got nuanced rheumatoid disease. As per national guidelines, can you refer the patient up to the local service? There we go.
I've heard before we've been told it's an inappropriate referral with, and that's a term. Well, tell me why it's inappropriate then. You know, I said, see another GP with the same letter, they saw another GP, got the answer we wanted. Never did find out why that wasn't inappropriate.
Unfortunately,
you're an osteopath.
Yeah, it may well be that. It may well be that. It's because
we've all done it.
To be an end doctor, a consultant GP, you've got to be bloody arrogant. My wife told me that. And you've got to be a bit strange, because the training programs really do. If you're pleasant, you've got to be a bit unpleasant to get there, because it's a horrible. The life we do, that program I showed you, what we had to do, I would never do that again. And if I knew now, if I knew then, I knew what I knew now, I would never have done it. It was horrible. I say to the junior doctors underneath me, your most vital years of your life, in your 20s and 30s, you just put a line through them. And for women, basically, if you want to finish that, you've got to hold for home babies, because it's going to be impossible to finish if you do that. And it really is hard. Women really have it bad in this, because once you have babies, your training pathway just slows down considerably. And that's why a lot of consultants when with women consultants, they wait till they get the consultant post in their mid-30s before they start having kids. And those who don't, they don't finish that program for another 10 years. And that's when you're up all night doing medical on calls. And it really is, it is unpleasant. And that's what, and if you survive that, you're a bit weird. Most of the people I train with didn't finish. They felt it was like last man standing really. And I only survived because I was bloody-minded, because they beat me. But I came close a few times to quitting. So it's not, and that's the sort of mentality. And so this sort of, I'm made up. We are, doctors are arrogant, yes we are. I am as well. I think I know all. I told you everything. I said, this is all wonderful, this is all correct. Actually, this is all my hypothesis. Somebody else could, you could put this on the internet and somebody could rip it apart. And they would be, you could pick holes in all the arguments I've made, because that's just how it is. But there is something, well, osteopath, what do you know? You're not going to go ahead of that.
I actually had a GP say, and I quote, I don't read osteopaths' letters. And it turned out, only because this patient is rather well built, let's say, and slightly rough around the edges, leant forward and said, "You will read the letter." The doctor went, "Okay then."
Well, just
and then did read the letter, and it went to surgery, and it was a valid referral.
Well, I get a lot of letters. They're very, very long. Okay. What you want, what the GP wants to know is, what's the diagnosis and what they've got to do.
Yeah.
Dear GP, this patient has got a meniscal tear. They need to see an orthopaedic surgeon. The end. Love and kisses. That's it. They don't want to see all the stuff about what to do on the exam. That's what they want to know. That stuff as well. But that's all they'll read. They spend. A partner in a general practice works 80 to 90 hours a week, and they get piles of correspondence to go through, and they want it simple and quick as possible. I get a lot of letters. I just skim them. I say, what do they want me to do? What do I need to do? If it's not something I need to do, I don't even read the whole thing. I don't have time. I don't have time to keep it simple. But it is, dear GP, this patient's got acute. This patient has developed acute rheumatoid arthritis. Because if they don't do the referral and something goes wrong, then they will get sued successfully.
Exactly. He could have done.
Do they worry about false referrals, as in like when they send, send someone to you and you go?
Well, they may look at the patient and think, actually, I don't think this is rheumatoid disease. I think this patient's got osteoarthritis, or I think they've got carpal tunnel syndrome, or they've got something else. Fine. But actually, if you think all those joints are big and swollen, then that's what it's going to be, isn't it? As far as I'm concerned, it looks like a duck walks like a duck and quacks. It's probably a duck, isn't it?
What about the patients that just get it in their hands? They have no other complaints apart from they're a bit stiff in the morning. But that's quite a lot of people. They just have swollen.
It's called getting old. It's called getting old. A friend of mine, because I mentioned a friend of mine about this the other day, I said, I'm a bit stiff in the morning. And he just looked at me in the eyes and said, if you don't have pain when you wake up in the morning, then you're dead. We all get a bit of that. Osteoarthritis, wear and tear arthritis. Osteoarthritis is ubiquitous. We all get it. As I said, I get lots of weird stuff. I do lots of weird stuff. And the medical students love all the weird stuff I do. Vasculitis, lupus, and Sjogren's, all that sort of stuff. Love that. And so one of the lectures I do is on osteoarthritis. So I start with them. I say, right, guys, I'm sitting there and find so I'm going to talk to them about osteoarthritis, and they go, oh God, can we get out? So I'm going to present a case. I'm going to present Sue. Sue, she's a 73-year female. She's got arthritis, osteoarthritis in her knee, and she's got it in her back. And then you can see them going, God, what are we doing here? This is tedious. Go and have some lunch or something. Then cytoition as well. Let me show you a picture of Sue. I'll show them Sue. Sue is a Tyrannosaurus Rex. She's 73 million years old, and she's the most complete T-Rex skeleton I've ever found. She's in the University of San Antonio. I went round her with a camera, and she's got arthritis in her back, and the fingers as well. And then once you show students, the two things get together: pirates and dinosaurs. All kids love those, don't they? And other pets, I don't love pets. But once you mention sort of dinosaurs, you've got them all engaged. And that engaged them, just to make the point that actually all creatures get osteoarthritis. In fact, the interesting thing about that skeleton, so I'm going to digressing slightly again, is this skeleton actually had healed rib fractures. If any of you know about your carnivores, if a tiger fractures a rib, it dies. It starves to death. If a carnivore has a rib fracture, it cannot hunt successfully. Something must have looked after this so the ribs healed. This is why we think they may have been pack animals.